Regarding older patients as well, there was a similar sort of general agreement regarding the approach, but some discordance regarding some of the nuances of the therapy. So I think in general, there's an agreement that older patients probably can be managed less intensively. Many people suggested that bendamustine was their primary modality or chemotherapy for frontline treatment of older patients, but that was not universally true. R-CHOP and the VR-CAP backbones are still reasonable for older patients and have a lot of good data supporting them. There's interestingly some discordance regarding the role of cytarabine in older patients. It's clearly active in younger patients, and should we be withholding it from older patients based solely on their age? In France, it was interesting to learn that they still try to give it when they can. Maybe a little bit less common in the US. So that was interesting. And then the other interesting question was regarding rituximab maintenance following a bendamustine backbone, particularly in older patients. And it sounded like the majority of people were probably against it, although some people, including me, think that there may be a role for it. So it really is the same thing amongst older patients, where we have to take into account a lot of factors and try to come up with a regimen that is going to accomplish what our goal is, which is ultimately to help people live better lives without a lot of issues related to the lymphoma. And that's challenging in mantle cell lymphoma, maybe more so than in almost any other lymphoma.